Hey everyone, it's Sean Gibbons from the Communications Network. I hope you're doing well on what's a fairly warm August day in the Washington, D.C. area where I am. But you are not here to hear from me. You are here to hear from Dr. Richard Wenzel, who's coming back for the ninth time because this pandemic, I know, gang, we're all over it or we want to be, but the pandemic is clearly not done with us just based on some of the numbers we're seeing around the country and some of the debates that many of us have experienced firsthand with family or friends. Um, so we're going to hear a little bit more about what we're facing right now and what's ahead. We'll get to that in one quick minute, but as the room is filling up, I see y'all still coming in. Let's just do a couple things that we've made our practice over the last many months. One is, hey, Trishna, we are delighted to have you with us. So Trishna's already gotten out of the gate. Gang, if you would, jump into the chat box. That's going to be right down there at the bottom of your screen. You can manipulate that with your finger like I am or your mouse or whatever. Make sure that the chat box is open and it's talking to all panelists or attendees, or sometimes it says everyone. Go ahead and type in, if you would, your name and where you're coming in from. And then this idea that we borrowed from Professor Brene Brown down at the University of Houston called the two-word check-in. And so it's two words. How you feeling just now? And for a lot of us, lots of emotions here. Hey, Jay, how are you? Grateful and determined. Glad to hear it. Kay, how are you doing out there in Virginia? Betsy, lovely to have you with us. Thanks for being with us. Marshall, okay-ish. That's a way to be right now, right? Lots of polarities for lots of us, having emotions that are both positive but also negative, some gratitude and some anxiety. Mark, how are you? Discouraged? I'm sorry. Trishna, resolute. That's a good way to be. Suzanne in Santa Cruz, curious and tired. And I am envying your wave, Suzanne. I was out there a couple years ago doing the Sandman just down the triathlon, just down the beach from you. Tanya in Cleveland, motivated and hungry. Yeah, I guess it's almost lunchtime, a little after lunchtime for you, so you should be hungry. Susan, kinda done. That's what we're going to talk about. I think everybody's a little kinda done, and yet 160,000 of our fellow Americans have passed away due to COVID-19, and that's just the numbers we know. 5 million plus cases now here in the United States confirmed. And again, those numbers could be quite a bit higher. Let me tell you one quick thing before we jump in, and go ahead and let's talk to everybody. Hey, Deborah, how are you down in St. Croix? Hopeful, more hopeful than usual. Good. And also a little sad. Yeah, that's the way we're all feeling. It's just hopeful, willingness to be over, and also this sense of sadness and loss and anxiety and all of these different emotions. And they're totally okay. They're entirely natural. Many of us have been at this now for many, many months. Covish, Anna, I like that. Covish. That may become a new word for us. That's a pretty good descriptor. I know exactly what it means, and I don't know what it means. With that, hey, Mr. Tristan Mahabir is running the deck for us. Our colleague Kareem Alston is taking notes. Tristan, if you take it ahead, I just want to let y'all know this. Nancy in Cape Cod, oh, I could go for a Wellfleet oyster right about now. Even better, I could go for your weather. It's a little bit hot down here in DC. Jasper hanging in there in Morgantown. So you should see this little thing popping up on your screen. It says Com Network V. This is the event that we are going to be hosting. Normally, as you all know, the network gathers in person. Last year, we had about 1,000 of us, or almost 1,000 of us down in Austin, Texas, and it was a beautiful time. None of us, not a single one of us, thought that as we were gathering or saying goodbye to one another, that it would be more than a year that we would have an opportunity to get together again. But of course, that's going to be true, because what you see here is not ComNet. Com Network V is a whole new event, and it's going to be virtual. The great news is it's free. So if you'd like to be with us, we'd love to have you. We have a tremendous lineup of folks. Nicole Hannah-Jones, who did the incredible 1619 project through the New York Times, re-reporting American history from the arrival of slaves and making that experience central to the story of America in a way that many of us have not been familiar with or hadn't experienced in our school experiences and learning. We're going to have Dr. Richard Besser, who is the former head of the CDC, now the president of the Robert Wood Johnson Foundation. He will be with us. Alexis McGill Johnson, she has now recently been named the CEO of the Planned Parenthood Federation of America. Previously, she founded and runs an organization called the Perception Institute. She thinks a lot about racial bias and the brain, and how we all are sort of wired to be a bit prejudiced, often without any good intentions to doing so. It's that unconscious bias that many of us are now learning about. We have some other voices be with us. Renee DiResta, who is just incredible. She works at the Stanford Internet Observatory. She's literally taking the internet and thinking of it the way astronomers do space. She's watching memes and nefarious activities and all sorts of things erupting online. And she'll talk to us about misinformation and disinformation. So there's all of that, plus a ton of breakouts. NPR, StoryCorps, National Geographic, United We Dream, Raíces, that wonderful group down at the border, all going to be with us, sharing what they've learned over the last year. So I encourage you to be with us. You can learn more about that at Com Network Virtual. .org. So Com Network Virtual, just go to comnetwork.org and we've got links to get you there. So hope you'll be with us. And actually, Kareem beat me to it. There's a link in there because of course there is. All right, so with that, let me stop yakking at you. We got a nice group of folks in here. Already got some questions. I'm sure you do. We will get to as many of these as you can, but I'm going to pass it now along to Dr. Richard Wenzel, who has been with us now, gosh, since March. Very, very kind of him to do so. So let me stop yakking at you and let him take it away. Doctor, if you would.
Thanks very much, Sean. And Tristan is behind the scenes. Thanks. The title slide is just a reminder me to tell you my email is included here. There's some people who don't like to ask questions in the group, or that we may have not time to get to it. I also want to remind you that I may mention the names of companies that make vaccines or drugs or name the drugs. I have no conflict of interest financially at all or in any way with any company that deals in drugs or products. Next slide. So the title of this slide is DNA from Prehistoric Humans, Evidence of Epidemics from Animals 5,000 Years Ago. And if you look at this picture on the left, it's a skull of someone who lived probably 5,000 years ago. And it turns out that the pulp inside the teeth can be protected for thousands of years. And you can actually, with very special techniques, examine the pulp and find organisms that actually were there or killed, in fact, the person 5,000 years ago. In bold down underneath, it says until recently, it was thought that the first pandemic of plague was 50 million deaths from Justinian plague in 8541. Turns out that was way off, probably by 5,000 years. By examining the pulps of teeth in these prehistoric humans, that actually plague was found inside. And I'll just tell you that if you look to the right, about 10,000 years ago, we began to, as a group of hominids, live in communities, have farming, raise animals. And again, if you look at the teeth of people at that time, the DNA from the pathogens in the pulp of the teeth yielded not only plague, which was probably spread from rats, of course, salmonella from a number of other animals, TB thought to be from cows. So that the point I want to make here is that zoonoses, infections from animals, very quickly followed on the heels of domestication of animals. And then as communities developed, then these infections could spread from person to person, epidemics. So it turns out, if you look at the bottom, communities of Europeans died out quickly several thousand years ago, thought to be by epidemics such as plague. And it opened the corridors to be replaced by migrants from Eurasia to move into that. So we have zoonoses followed in groups, epidemics. And then when the next slide, when moving around the different parts of the world, either by sea or by airline now, we have pandemics and rapid pandemics. So this is just a review of the plagues and people in the recent zoonotic pandemics. With the infection left to right, HIV, the chimpanzee is thought to be the reservoir. And although there's some argument about when exactly this landed in our country, 1985, it really took off in our country and then became pandemic. SARS and MERS and COVID-19 are all coronaviruses. The primary reservoir is always in the bat. SARS, the secondary reservoir with the civet cat, 2002 and 3, and point out that the civet cat was a eating delicacy, and that's in part why people got exposed to that. H1N1 influenza, swine flu, but it also had genes from birds, 2009 and 10. MERS, again, primary in bats. Camel, secondary reservoir, mostly stayed in the Arabian Peninsula. COVID-19, the pangolin, this anteater with scales on the outside, again, thought to be important delicacy for some populations, certainly in China. And so the questions I would ask you to think about as we go through these slides is, what did we learn that prepared us for COVID-19? And I'm worried that we didn't learn enough. Are we better prepared now for tomorrow's pandemic, Could I go back, please? One. And then to bring you up to date on the SARS-CoV-2 virus transmissions to animals from people now to cats, dogs, tigers, hamsters, ferrets, macaques, and minks. And not only for people to minks, but actually minks now in Holland back to farm workers, where they've had to cull thousands of the minks to try to stop this. So again, we have with transportation, epidemics converted to pandemics. Next slide. So one of the takeaway lessons I began early is COVID-19 is never going away. It's a highly transmissible virus. It's transmitted often by asymptomatic infected carriers. There's certainly an increasing number and variety of animal reservoirs, and we don't know yet how many of those animals will then transmit back to people. And it's true that we look forward to having vaccines and boosters and new drugs. We'll dampen the spread of the virus. We will not eliminate it. So the implications are that SARS-CoV-2 is here to stay, just as HIV, H1N1 influenza variants, Ebola, and others. Only one virus did we ever eliminate, and that's smallpox. Smallpox is thought to have originated from an animal still unidentified around the time of the Roman Empire, 2,000 years ago. And it evolved so that there is no other animal reservoir. So people were the only reservoir. There was no asymptomatic transmission. And so after 15 to 20 years, a vaccine and case finding was able to eliminate that virus only. So the bottom is more of a question. Will SARS-CoV-2 mutate, become less virulent? Some experts who study that say that the common cold coronaviruses listed here, the four, OC43, 229E, and O63, HKU1, were serious pandemics in the late 1800s. And they came from cows, and they evolved over the last 150 years to be now milder seasonal viruses. That's the hope. No definite experience now to say we know that to be fact. Next slide. So now I'd like to show you the international trend lines. And these are confirmed cases on the left of COVID-19 for selected countries, showing the number of cases from the day of the 100th case in each of the countries. So on the y-axis, I would point out it's a log scale, 100 to 10,000 to a million. And so on the x-axis, time 0 all the way up to 180-day follow-up. And what you would like to see is a very low peak in any country, and then immediately and sustained flat line. Since it's accumulated cases, the line can't go down. So unfortunately, you see the top orange line, US leads the world in total number of cases, followed quickly by Brazil, Russia, and Mexico. Those countries in Europe that are clumped together there, and Spain, Italy, France, and Germany, had a earlier lower peak, and they became flat now with their quick reactions and complete reaction. Similarly, China, really low peak finally, and then a flat line since. Japan and Australia had low peaks, and then they were flattening out. But you begin to see now, after 150 days, they relaxed, and we're seeing a little bit of increase there. If you look to the right, you can see the US cases are now 5.1 million. That's a quarter of all the cases in the world. And our deaths, 163,000. Now the poster country for me would be New Zealand. It went 100 days until 2 days ago with no domestic transmission. And only in the last couple of hours they announced new cases emerged. So the point about New Zealand is they did it well. They did the right things. They got out early. They did it completely. But this is a very unforgiving virus. And even with their success, they're beginning to see a few more cases. Next slide. Another way to look at data, a parameter of how well we're doing, is to look at per capita cases and deaths. So on the left, you see the COVID-19 cases per million inhabitants, and this levels the playing field. So the top three are Chile, Kuwait, and Panama, countries without the resources that we have, and yet we're number 4 in the most number of cases per million inhabitants. And then we're followed by Peru, Brazil, Singapore, Israel, Saudi, and the first European country, Sweden. So we're not doing well. We're in the top 4. If you look to the right now, and these are highlighted in yellow, we look at per capita deaths, so the number of deaths per million in the yellow. And leading the world is Belgium, followed by the UK, Peru, Spain, Italy, Sweden, Chile. Number 7, the USA, 7th highest deaths per million. So by crude numbers of cases and deaths, and then per capita cases and deaths, we don't have much to celebrate. Next slide. Now, it looks a little bit promising here if you're looking at our national trends. And again, on the left are new reported cases per day, 7-day average. And on the y-axis, you see the cases. This is a linear with 20,000, 40 to 60,000, and the time March through early August. And you can see in April, we were above 20,000, probably around 30,000. We were able to lower this down when we went into a kind of a lockdown, partial lockdown. By June, we were down to 20,000. As we opened up, though, you see the new cases went above 60,000. And so we're maybe in early August down a little bit below 60,000. We don't know where this number is going. Again, not a lot to celebrate. On the right, new reported deaths per day in the United States. Again, a linear axis on the Y, going up from 0 to 1,000, 2,000 deaths. And we peaked about between April and May, 2,000 deaths per day. And then in July, we actually fell down to pretty close to 500. But deaths really lagged 2 to 4 weeks after cases. And you can see as we opened up in June, July, and May, we now are up to 1,000 cases per day again. Again, not enough to celebrate. Next slide. Another metric that you might use to see how we're doing is to look at hospitalizations across the United States. So again, these are CDC data. They're very recent. And you can see on the y-axis, the number of hospitalized cases going from 0 to 60,000. And so if you look at the time on the y-axis, in mid-April, the epicenter was New York City. We had 60,000 hospitalizations for COVID-19. And most of the patients you can see were over age 50. Only 25% were under age 50. By June, we had partly locked down, and we knocked the number of hospitalizations, thank goodness, down to about 30,000. And then we began to relax again. And then you could see that we're back up by the late July to 60,000 again. Here, the epicenter moved from New York to the southern states, Texas, Alabama, Florida, Arizona. And the age group was now falling. 40% of the patients were now under age 50. We're up to 1,000 deaths per day. And I want to point out in August, it's very early, but it looks like we're at risk for new surges coming into the Midwest. Hospitalized patients are patients on ventilators, experimental drugs. They're isolated from the family. They're actually fighting alone and unfortunately dying alone. It's a big deal. Next slide. So again, I want to show you some painting, and this was from Edvard Munch, who lived from 1863 to 1944, a Norwegian expressionist. And he was the painter that did the Scream, the person that we all remember. On this slide, he shows actually the publication, the public angst, if you will. Anxiety was the title of this painting on the left, painted in 1894. And what Munch does, in the background, he shows you what was true yesterday or yesteryear. And you can see the familiar lake around Oslo, the sights, the peaceful, tranquil look with the boats, the church, the bright lights. And then in the foreground, he brings us up to today. And what do you see there is the anxious look of these people collectively. They're dressed in black, the symbol for death. So if you're feeling anxious, it's understandable completely, because what you can ask yourself the question, how did we get here so fast? What is tomorrow going to bring? I don't have control over everything going on. I don't see the real light at the tunnel. So it's not surprising that at least a third of us have some kind of anxiousness, as expressed here in this painting by Munch. Next slide. And for me, one of the concerns that I have that actually I think contributes to angst is that the perilous flight, I've used this analogy of a spaceship, our flight to controlling COVID-19. And I say it's perilous because we've sidelined science national. CDC, I wish, and they should have daily briefings telling us where we are, where we're going on this flight, what assumptions inform our current policy. They have failed to offer a national plan. The states are offering 50 disparate plans. They failed to have a national mandate for masks in public. Each state, each county have their own. And we should be having a national mandate for social distancing as well. And unfortunately, the CDC raised no objection when the state's data was ordered to be bypassed and not go to CDC, but a mandate that it had to go to HHS, Health and Human Services. So, and now Dr. Fauci, who has well over 70% belief, if you will, comfort by the public in general, who feel that he's being totally honest, is seen at fewer White House briefings. So on the right, it says, what makes no sense to me is in this flight, why would you sideline the pilot who's experienced and even in limited visibility and the crew, CDC? Why would you fail to file a flight plan? And that is to say, a national plan of this is what we ought to do. Why would you ignore the safety checks, not mandate the use of masks and social distancing, and hide the instruments? That is, the data that has been going directly to CDC from the states, now bypassing to go to HHS. Next slide. So another punchline, I think, is this. I think another lockdown is inevitable for most parts of the country. The current approach is failing. You've seen the data. We now know that a third of all cases since February occurred in the month of July alone. University of Washington models predict 300,000 deaths by 1 December. Other countries opened up only after one new case per 100,000 population per day versus our, in April and May, 6.4 new cases per 100,000 per day. And currently, we're at 17 new cases per 100,000 per day. We know that physical distancing, when we did it, reduced infections by 80%, and it improved substantially as you move from 1 meter, 3 feet, to 2 meters and 3 meters. So if you can stay away 10 feet or 12 feet or 15 feet, it's even better. And there's no question in my mind, listening to and observing the writings of economists, that the lockdown has to include a stimulus for essential workers and small businesses and to improve the economy. The economy will not improve until we can control this virus. Next slide. So one of the big dilemmas is, what about school opening? What we know, looking back to last spring, is that when closed schools, we had statewide reduction in cases and mortality between March 9th and May 7th. And if you look at the data on the right, you see that there was a weekly decline, 62% reduction in cases and 58% reduction in deaths as we kept schools closed. The decline varied depending on the pre-closing community infection rates. So if in the communities in the highest quartile infection rates, they still could lower their infection rate by 49%. Impressive. But those that had the lowest community rates already in the background were further able to lower their rates by 72%. So the key message is you have to know the background transmission rates in order to see how successful you might be with opening schools. It turns out that the lowest versus the highest background rates had 128.7 fewer cases per thousand, 1.5 fewer deaths per 100,000, that is. The overall impact of closing, national estimates of 1.37 million fewer cases over the 26 days that were followed, 40,000 fewer deaths over 16 days. So we know that closing school worked. Next slide. Now, a little bit of insight might be to look at summer camps, which unfortunately many closed after coronavirus infection, despite having a lot of outdoor activities. This on the left is by far just a tiny sample of what's in the newspapers every day. An Arkansas camp for teens, 31 were infected as soon as they opened up, versus only one case in the county where that camp was. In Missouri, mostly teens, 82 campers, counselors, staff became positive within a week. YMC camp in Georgia, there are several that closed down, 85 in the one camp here, a couple hundred in another camp. Camp Pine Cove in Texas for 8th and 9th graders. The camp didn't release the numbers infected. In Raleigh, North Carolina, 2 camps closed down. The message here, teens are very efficient transmitter of SARS coronavirus 2. A study from China showed if you look at families and the teenagers are the index case, there's a 20% transmission rate in the family. If you have the children who are under age 10, it's 5. Teenagers are very efficient at transmitting and getting infected. Next slide. Go ahead for the next. So part of the concern I have is we failed to recognize the increasing evidence for aerosol transmission of COVID-19 inside enclosed buildings. So there's some evidence, levels of evidence. In one study, 13 patient rooms, patients with COVID at the University of Nebraska were sampled, 163 samples. 62% of air samples showed the RNA of the air samples. 71% of surface samples, such as the bed railings and the computer device, were sampled, and they were positive. The investigators went on to culture a subset to show not only that the RNA was there, but viruses capable of growth were also found. The highest concentration in air handling grates. In a separate study, 30 patients were studied and their exhaled breaths were positive in 17% for the RNA, and the air samples themselves generally 4%. Study of restaurant spread in China, choir spread in Washington State, and open shopping mall in China, where all the people were there who got infected, but in no case were they within close contact, saying that it wasn't close contact, it was airborne. And the newest models of the Diamond Princess, shown on the bottom right, for their spread of hundreds of cases, most likely show that the spread was aerosol at short range. Really surprising, not large droplets, but aerosol. So we need to spend more time, if we're thinking about opening up schools and businesses, on what the environment inside will look like. How do we clean the air? Next slide. So it turns out that the coronavirus infections have been linked to US colleges in the beginning of the epidemic, and 6,600. And so as these schools that have had some experience in the spring plan to open up, I want to show you what their decisions were. So you can see they were either primary or fully online, 87 schools, a hybrid in the middle, 51 schools, colleges, primary or full in-person, 95. Now, if you looked at color coding, wherever there were dark red, if you will, or orange, they had more than 50 or 11 to 50 cases. And you can see that no matter what your decision was coming up to be fully online, these 87 schools, they had a lot of experience with a high number of cases. But so did the hybrid schools that plan to go part online, and part in person. And the primarily or fully in person, those 95 schools had just as much experience with more than 50 and 1150. So they didn't make their decisions based on the past experience. They made their decisions on something else. And I'm guessing it was probably finances. Next slide. So my suggestion for school opening considerations is that you ask yourself the following questions. Community transmission rates is the key starting point. Your success in keeping schools open will depend on having a low community transmission rate. When he was asked, the head of CDC, Dr. Redfield said, it should be less than 5% positive tests. Well, let's see how we're doing. So I think we need to have a lot of testing, and I would hope that we'll use the rapid testing, which we'll come back to in a few minutes. But if you're doing testing, the questions are, who's going to get tested, what tests, and what frequency? With masks, what masks, who's going to wear them, exactly where, how will it be enforced? Physical distancing, how will you do that on a bus if it's open, classroom, and the restroom, and even the lunchroom? Disinfectant surfaces, what surfaces, how often? Hand washing, where will it be available and how? I'd like to spend a moment just to say we really haven't talked enough about keeping the clean air in the schools. Shouldn't we open up the windows? That would be my suggestion. Can you teach outdoors? Do you have the facility to do that? That would be wonderful. How many air exchanges are you per hour? Can you increase that? It turns out, if you look at the times today, the number of air exchanges in most schools is about 4 to 6. In businesses, it's 6 to 8. In the subways in New York City, it's 17. We should do as well as the subways. Can we put the HEPA filters in to keep the air clean? And I would really encourage schools to study the use of placing UV lights with safety protectors so nobody gets sunburned. But we know UV lights will kill viruses. And I was encouraged this morning to see that the subway system in New York is experimenting now with putting UV lights in the subways. They're going to have very safe subways. We need to do the same with our schools. Administrators need to know how many days a week, how many hours per day school, who's going to communicate, what will they communicate. And I really would suggest that they play very hard with the what if. What rules will cause us to close the school down? How many infections in students and staff and the professors? And how many people get hospitalized or worse, get in an ICU? We should be wrestling with these tough questions. Next slide. So briefly summarize SARS biology. It gets into the body through the pulmonary system on the left, and then transmission to other people by either large droplets that fall to the ground within 20 feet, not necessarily all within 6, and the tiny droplets or aerosols that hang around even after the person's left for 2 hours or 3 hours. In the body, if you look to the top, the virus gets from the lungs into the blood vessels. All blood vessels have this thin layer of very smooth endothelial cells, but they have a receptor that allows the virus to attach. So as they feed oxygen, blood, if you will, to all the organs, to the heart up top, to the brain, to the kidneys, you can have organ failure if there's any kind of inflammatory reaction. Or the second thing that can happen, the inflammation that happens with this disease can cause abnormal clotting, oxygen deprivation, and organ failure as a result of not getting blood to any one of the vital organs. And then as inflammation is uncontrolled, then you can have something called a cytokine storm and multi-organ failure and shock. And so the goals are, one, to stop the virus from multiplying, and we have one drug that's approved, remdesivir. And then you want to stop the inflammation, and we have one drug, the steroid, the anti-inflammatory dexamethasone. We have no other drugs that we are fully approved. Next slide. So just a little bit of the clinical things. If you look at the map on the left, and you can see that Italy and the Lombardy area, which was the epicenter, and the people there looked at out of hospital cardiac arrest. So the heart's involved with COVID. And they looked at the first 40 days of COVID compared to the same time, 2019. The number of cases of out of hospital cardiac arrest in the 2020 was 362, which is 58% increase over 2019 same period. And 77% of the increase in these out of hospital cardiac arrests was attributed to COVID-19, the virus. Now, was it that people got delayed entering the hospital or that the COVID attacked the heart so quickly they couldn't get there? We don't know. Interesting, the EMT response time for those people in 2020 was 3 minutes longer, probably reflecting a problem with all the other emergencies. Proportion of CPR, resuscitation by bystanders, in 2020 fell by almost over 15%. Again, probably people concerned about what they might be giving chest compressions to and getting exposed. Next slide. I'd like to pause here and look at COVID and pregnancy. These are high-risk patients or people who need to be protected. And just to go over some of the studies that I can summarize. In June, CDC reported data on a 28% sample of women of childbearing age, over 8,000. Pregnant women with infection were 50% more likely to need ICU care and 70% more likely to need ventilators than their non-pregnant, but actually co-infected COVID-19 infected peers. 50% more likely to be in the ICU, 70% in ventilators. A Swedish study reported in July, 4-week study of all women who were childbearing age. There, the data are even more threatening. If you were pregnant with COVID-19, you had a 6-fold more likely chance of needing ICU care than non-pregnant COVID-19 matched age peers. A US study showed that 79% of pregnant women with COVID-19 are asymptomatic. Maybe that's the good news. And this isn't the only virus to do this. H1N1, we saw that pregnant women represented 5% of deaths and only 1% of the population. So they were overrepresented 5-fold. SARS also had the more likely need to be in the ICU of pregnant and to die than people of the same age but not pregnant. So we need to protect our pregnant population. Next slide. There's encouraging data, and I will point out this is not yet published, it's available, but not peer-reviewed yet. So this is a meta-analysis looking at the evidence favoring the efficacy of convalescent plasma for treating COVID-19, looking at reduction in mortality. 804 patients, 12 studies. 3 of the 12 studies were the gold standard randomized controlled trials. 5 were matched cohorts, and 4 were case series. And on this plot, what you look down the 1.0, the odds ratio, there would mean there was no difference between those who got plasma versus those who got the standard therapy. And what you want to look at is if it favored the alternative therapy, most of the dots would be to the right, and if it favored convalescent plasma, the dot and the confidence limit would all be to the left. And you can see that all the estimates, the point estimates in these 12 studies all favor the convalescent plasma, reducing deaths. And if you look at the bottom, the green dot and the green confidence limits, what this says is the point estimates of what happened here is that over 50% reduction in death in patients that received the convalescent plasma. 57% is the estimate with the confidence limit show. So we're not yet at the point where the FDA has approved this yet, but when this study gets published and peer reviewed and maybe other studies, we may be doing this. Hospitals are already doing this, and I know studies are already underway. Next slide. So recently, the governor of Ohio, Mike DeWine, had a rapid test because he was going to entertain a visitor at the White House, the president. And what happens in all such instances is that people are tested, and even though they're asymptomatic, as the governor was, they get a rapid test. And the rapid test was positive. And I'd like to show you why we should have known that later it would turn out to be a false positive. So the prevalence, if you will, in Ohio is 6%, and it's shown on the map. So if 6% means that for every 1,000 people in Ohio, 60 will have infection. And it turns out that the rapid test has an 85% sensitivity. You'd like to see that 95 to 100. So it's not as good as the longer taking test that we look for, the PCR test, which is 95 to 99. So go over to the table here. And what it shows you is top infected, non-infected, and total. So for every 1,000, we see the total, 6% or 60 will be in that line under infected. That means 940 will be in the middle, non-infected. Now, if the test picks up the infected people 85% of the time, the test will be positive 51 out of the 60 and negative in the 9 on the left. So 60, the prevalence, the test 85% will pick it up. Of the non-infected 940, the test is better. The specificity will identify 95%. So that's the 893. But it'll still show 47 to be test positive when in fact they're negative. So now look at that bar left to right, test positive. 51 of the infected, 47 of the non-infected, 98 total. But in fact, of all the 98 who were test positive, only 51 really were infected. That's a positive predictive value of 52%, shown in the bottom, highlighted. And I want to tell you then that with that low prevalence of 6%, 6.0, you're going to have half the people are false positive. And the only way to get fewer false positives is have something like a 50% prevalence, which we don't want to see right away. But where do we see 50%? In busy emergency room with people who are short of breath, have abnormal chest finding, have chest pain, sore throat, body aches. We know that a lot of those people, 50%, might have COVID. Very few false positives. But what they do have is increasingly false negatives. So if you're getting tested and a low prevalence, a lot of false positives, very few false negatives. Next slide. Bring you up to date on the vaccines. We have 165 vaccines under development, over 140 preclinical phase, meaning testing in animals, 18 in small numbers in humans, 10 to 20 people, and 12 in phase 2, maybe 100, 200. Phase 3 we have, or will almost have any minute, 5 that I'm aware of, and this can change quickly. The NIAID, National Institute of Health, Moderna, and the Pfizer BioNTech are already in phase 3. Each phase 3 vaccine will have 30,000 people. The top two, the Moderna and the Pfizer, are both messenger RNA vaccine, brand new type of approach, and they're very flexible. In terms of others either on or coming any minute, there are 3: Novavax, which is a protein vaccine, and you hope you'll make antibodies to it, and it'll be the spike protein. Very similar kind of platform as we have for hepatitis B. Johnson & Johnson and Oxford vaccines, also in phase 3, use a viral vector, which means there's a very harmless common cold adenovirus with a gene inserted that makes the virus protein to COVID, and we hope we make antibodies. So with luck, we'll have early results in November and 100 million doses per successful vaccine. The one sort of concern that some people have raised is with these new types of virus you might have enhanced immune response. And that means on the T cell side, these are the frontline soldiers that really kill a new virus they haven't seen before. You could have an over-inflammatory response infiltrating the liver and the lung. So far, no one has seen that. And the second, on the B cell side, the neutralizing antibody side, you might have non-neutralizing antibody that binds to new infecting virus, promotes weirdly increased virus uptake in the cell. And so Peter Hotez just wrote that up very in the last couple of weeks. Potential, low risk, but possible. We'll be looking for that. The second problem will be recent polls suggest that 20%, maybe as high as half respondents will decline a vaccine. So we have to be able to deal with that. Next slide. So I want to leave you with some general themes. Physical distancing, at least 6 feet, and more is better, is the most important response we can have, more than even masks. Imagine if people stayed no closer than 10 feet. We would really dent this virus. Masks will work, they're very useful. We need to wear them properly in any kind of crowd. Outdoor is much safer than indoors. The crude rates indoor are 20 the outdoor rates. Airborne transmission clearly occurs. The question is, what proportion of transmission are airborne? We need efforts, as I mentioned earlier, to keep indoor air as clean as possible. School openings, the major driver of success, will be the community level of transmission, and then not drop our guards as they did in Israel and say, well, they're low, they don't need to wear masks. Continue to do that. Next slide. And lastly, I think what we have to do is look at this year as really a bad year. We usually like to think that, well, we'll respond to us. Over 3 months, we'll get over this new epidemic of influenza we have every year. Or in 3 months, we'll get over the new terrible hurricane that we had. Our vista has to be now, not 3 months, but 12 to 15 months. 2020, that's the year of uncontrolled COVID, a lot of terrible disruption. 2021, we're going to begin to see by mid-year COVID-19 control led by science and public health. And the question is, well, when will life really return the same? When will we be able to attend the concert at the Met and maybe see Renee Fleming shown here on the left? Or when will we go see To Kill a Mockingbird in one of the theaters in New York? We're trying to respond to those organizations, nonprofits that are trying to get us in contact with our humanity. I think we'll see that towards the end of next year, but it may be different. We may still have to wear masks to see Renee Fleming and listen to her. And similarly, it wouldn't surprise me that the Met or the Broadway theaters do something to improve the air handling. Maybe they'll think about air handling, air samples, changes per hour. Or maybe they'll think about HEPA filters or experimenting with UV light. But I think we have to have that positive view looking to the end. Let me thank you here for those of you who are tuned in, and I'll be happy to answer questions that may come up.
We have a number of them, and gang, as you know, you can vote for questions. So the first one, Dr. Wenzel, we have 12 questions now and probably a few more coming in. Derek, our colleague, asks, how might the asymptomatic people, estimated recently as up to 40%, be key to solving the pandemic? So how can we help, given the fact so many folks appear to get infected, but to have no knowledge that they're infected, have no symptoms, are they the key? And if that's the case, what do you do when you have an asymptomatic carrier?
Well, you don't know who they are, of course, all the time unless they're testing frequently. So I would really say one of the first things we could do is test people. And we've got to get our testing into the rapid phase. We can't afford any longer to have 12 days to know, for example, if an essential worker is positive or negative and they can't stay away from the cafe. So testing. The second thing is everybody has to use a mask whenever they're in public and close to everybody else. And we have to adhere to all the other rules of social distancing. So I think testing is critical, and then hanging in there with all those things we know work. Social, physical distancing, the use of the mask, cleaning the surfaces, hand washing.
Following on from that, and you talked about this just a moment ago on the slide, do you anticipate we're going to be wearing masks in 2023, going to a college basketball game or going grocery shopping?
I think a lot of that, it's possible. I would remind you that the people in Asia have been wearing masks for a long, long time, decades, even with common cold viruses. And what we're going to find, I think, as we did already in earlier spring, wearing the mask and social distancing absolutely rapidly cut down on the epidemic of influenza. And we still had some control over a period of weeks of the COVID-19. So I think surely in the first half of 2021, we'll be wearing masks. And a lot depends thereafter. One is how we adapt as a country socially. And the second is what data do we have to say what our threats are.
Understood. Our friend Nancy has a question. She says, Dr. Wenzel, you stated that COVID-19 is never going to go away. However, you also state that shut down schools will help with the rise in cases. If it's never going to go away, how long can we live in quarantine and maintain a life with sanity? The question, that is maybe the definition of COVIsh, right?
Yeah, absolutely. This is what we're all wrestling with. And what I really mean by if you're closing the schools or you're doing everything right, if you decide to open and we have fortunate community, you will really dampen the transmission level and the height of the number of cases that we have, new cases per day or cumulative number of cases. And eventually, I think what we'll probably have is this may turn into like an influenza. If we get a so-so vaccine, we may be actually getting the vaccine once a year. Or if it's maybe the immunity will last 2 or 3 years, we'll get a booster every 2 or 3 years. We're still going to, perhaps, and relates to the earlier question, we still have to do the right thing to control this in the meantime. But even if we do everything right, I don't think we'll get this down to zero. It's just not going to happen.
So a couple of related questions. So one was you talked about the vaccine. You and I talked about this before we got online, at least a couple of weeks ago now. Quite likely you're going to need more than one shot. So if you're talking about 100 million doses maybe on day one, you're actually talking about potentially 50 million people getting the vaccine. Is that correct?
That's correct. And assuming we have only one vaccine and it's efficacious, effective in cutting down infection, as the FDA says, at least 50%, we'll have 100 million doses per effective vaccine. If we're lucky, of the ones that I showed you in phase 3, maybe 2, maybe 3 will be there. So if we got lucky and had 200 million doses or 300 million, means that half the number of people, instead of having just 50 million people get 2 shots, we might be able to get up to 100 million or 150 million.
So the other question, and we talked about this just before we went online, is, and we will get to the other questions, game, but I thought this was interesting and worth you hearing, is a vaccine could get approved that's maybe 50% effective.
Yeah, that's what the JAMA article very recently said. The FDA, that they promise they're going to be strict, they won't be influenced by politics, what they're saying, and they're going to stay by the rules. And they usually don't do this, they say, about a vaccine, tell you what the efficacy has to be. But they said they did this to encourage people to have confidence in them, because a lot of people don't have confidence in them. They actually said, we're actually not going to look just at the 50% point estimate of reduction. We're going to look at the confidence limits around it. And our lowest acceptable level of confidence limit will be 30%. So 50% is the point estimate. The low might be 30, the high might be 70%, could be how effective the vaccine is. And what we say by confidence limit, truth is somewhere 95% likely in there. So they've come out and gone on record as saying they're going to be strict, they're going to follow all the regulations, they're not going to rush this through, they're not going to push through an unsafe vaccine, and they have not going to be influenced by politics. We'll have to wait and see.
But again, forgive me, I should have gotten beyond AP Bio. So does that mean that there's a very real possibility my wife and I could each get a vaccine dose? Presumably we will when it's available, maybe sometime next year. And Dana might get it and she's not protected at all, or she's got a 30% effective protection and I've got 50 or maybe even 60% effective. Is it going to
Well,
vary from person to person, or is it really have more to do with the efficacy of the drug?
well, what you really want is the population to have at least 50, and maybe that's not enough, but hopefully even as high as 70%. Most of us think that if you have 70% of the population that's immune, you will stop this epidemic because you'll run out of hits. The virus will just run into too many immune people to be transferred to some other person or groups of people. So 70% would be the ideal goal. 50% is still going to interrupt a lot of transmission. It means we may not get rid of the level, but the peak will be much lower. And that's what we're hoping. In the meantime, maybe we'll have better drugs.
Gotcha. Okay. And Merle asked in the chat, because I'm monitoring that too, quick question, which was, we talked a lot about aerosols this time. So masks, indoor air quality, less about surface contaminants, but you did mention in one slide, lots of contamination of hospital rails, the air grates, and several of the other surfaces. So with regard to all of us who are picking up the mail or going grocery shopping, should we be wiping stuff? Just the practical questions. Are we wiping everything down? What do we need to be doing there?
Yeah, here's what I think. I think that the surfaces are contaminated, certainly in rooms of hospital patients. There's less contamination in the public, but there's some. And I think that the lowest bit of data that we have, the least confident we are, is how much infection there is from contaminated surfaces, touching it, then touching your face, your eye, your nose, or your mouth. Obviously, if you wear a face mask and goggles, protective gear, you're going to cut that out. If you wanted to wear gloves, you could. I think we don't have to worry so much about surface transmission as we initially didn't know much. But what it looks like is well over 90% is transmitted by droplets, either small or aerosols or larger droplets. There are very few data that even can say we're likely to get transmitted. So I don't think that we should wash any of the produce that we see at the store. If it makes you more comfortable to wipe down, let's say, plastic surfaces, because we know virus can live on there for a while, I would never tell anybody not to do it. I don't think that's a really big risk. I think it's really droplets.
So you're telling me I can get off of this and tell Dana to stop going at the groceries with the Lysol wipes every 2 seconds.
Yeah, I wouldn't Lysol any groceries properly, but if you wanted to do, hard surfaces like plastic, yeah, go ahead.
Okay. I'll get back. Sean's question, gang, you can also vote for these, remember. And I saw your question in the chat about the Russia vaccine. We'll get to that in a minute. Sean says, why are infections skewing younger? Is it simply due to individual preventative measures, or is the virus mutating?
Well, that's a great question. I think in part, we're talking about essential workers. Remember that in some states, 40% of the people who are getting infected now are Latinos. People of color have always been very high. The indigenous populations anywhere in the world. So these are people who work and live in very crowded conditions, many of them so-called essential, who were threatened by the virus and their company, caught in between that. I feel sick. Do I go to work? I feel sick. If I don't go to work, I don't get paid. So these social business pressures, the fact that they're in a social condition where there's crowding at home and at work. So the people who are at meat packing plants up in Alaska, they're seeing fish packing plants. Same thing, indigenous people as well. So the crowded, again, that theme seems to be coming in. And again, the second thing that happened is when we opened up, particularly in the South, it was young people who said, look, I've been doing this for a while. I'm going to the bars. I'm going to the nightclubs. I'm going to the beach parties. I'm going to the house parties. So they threw caution to the wind and unfortunately found out that, young adults are not immune. and some of them got infected, some seriously infected. So I think those were the social forces operating that mean that our age has gone down considerably, down 10 or 15 years, in some states, even more.
Okay, next question comes from Bill. I haven't seen scientists out in front demonstrating causation or correlation between school closures and reduction in cases and deaths. Why not? Or have I missed it? Or have their voices simply been drowned out? Feels like there's so much opportunity out there for the science communications community during this crisis.
Yeah, I showed you the data. It definitely works. And I will join you in being really disappointed the fact that we marginalize science. Dr. Redfield can't say anything unless he gets permission from the White House. I wish he would stand up anyway. He's at risk for a rebuke. He's at risk for getting fired. The FDA, Stephen Hahn can't say anything without getting permission from the White House. I wish he would stand up, say what's on his mind, and we're counting on him to stand up and be accurate when it comes to looking at new drugs and new vaccines. So I'm with you. I'm frustrated. Tony Fauci, who used to be at every one of the briefings, now is seen at fewer and fewer, and he's being rebuked by some people in Congress.
Related to that question, many of us have seen an interview that the president or the current president gave with Axios. It's a new news organization, was on HBO. And the president was showing data that seemed to give the impression he believes that the country is doing much better than it is. Did you happen to see that? Any reactions to that?
No, I've seen clips of that. And, this is a kind of, say, an optimistic president. But I've shown you the data, and whether you look at new cases per day, new daily hospitalization rates, per capita rates of infections or deaths, the total cumulative number of either one of those, we don't have a lot to celebrate. And I mean, the same president told us that it was a hoax first, and that it was a small numbers would be involved, it would disappear in the spring. It's good to be optimistic. And I think that is perhaps a part of the personality we'd like to see in leaders. But the optimism has to be driven by science. Science is not to be driven by the politics.
Okay. Next question comes from Susan. As we talk about sending our children back to school and into daycare, how likely are the grade school children to spread the virus? And how about preschool children? We know teenagers, but
yeah, it looks like the most active spreaders, and maybe for a number of social reasons, are teenagers or children between ages 11 and 19. Their rate of transmission is probably 4 times that of a child 1 month to age 5, and somewhere a little bit higher, maybe in the 5 to 10-year-olds. So that's the general guideline. Teenagers is where we like to see the spread. We've seen it in summer camps. We've seen it in schools already. We're going to see it in colleges when they open up. The question is, of course, can we stay open? And that depends on a lot of things that we've already talked about.
And is that because of is that literally because of socialization or behavior? So, your 12-year-old, 13-year-old hops on a bike, goes out and hangs out with the buddies in the neighborhood, whereas the 5-year-old, 6-year-old doesn't have the same agency, can't wander off without mom or dad?
Well, the answer is we're not totally sure. It may be that the young people have had coronavirus common infections in the past, and they still have some antibodies that might cross-react. That's one theory that's out there. They've also are people who've had a lot of vaccines, and they might have immune training, as some people are saying. Turns out populations who have a series of vaccines do better in terms of severity than populations who have very few vaccines. But the quick answer is we don't know, although we do know from vaccine studies that they are the most sociable population by age, teenagers. And vaccine companies have actually said, if I had to give a vaccine to any group, it would be the teens.
Related question. Flu season coming up. Should we all be going out to get a flu shot?
This is the year to get the flu shot. We know that the flu vaccine is not terrific. 50, 60% effective in preventing flu. That's not great. Probably higher in preventing severe flu. It will keep you out of the ICU closer to 70 to 80%. What you don't want to do is get flu this year. Have to be in a doctor's office with people with ongoing COVID and maybe picking up that or even risking that, giving flu to someone who has COVID. So I would say get the flu vaccine this year. This is the year to get it and get it early. And I wish CDC was already had a month-old program of encouraging people to get the flu vaccine in September. And if you need a booster by February, because it was a late flu, surprised us, go ahead, we'll get that. The second thing about flu is we know that there are a number of drugs that are out there that if you take one a day in your high-risk population, such as nursing home patients, this, while it's not a great treatment for flu, reduces flu disease by a day, it's 90% effective in preventing flu. It's a great preventive drug. So things like Tamiflu and new drugs that are out there, one a day, high-risk population, even if the nursing home patients got the flu vaccine. During that 4 to 6 week window when flu is peaking, they should be offered that at free or low cost. Other high-risk populations, the same thing.
Betsy asks, what's known about the Russian Sputnik vaccine that was released without phase 3 trials? What do we know about what the Russians announced? I think that was today or yesterday.
Yeah, it was just today, or maybe last night, that it was released. Putin said that Russians were the first to get an effective vaccine. There are no data provided. And I think we have to be driven not by statements, but by critically examining the data. We don't even know phase 1 data. Does it, hurt small numbers of people? Did they get an immune response? Phase 2, if you gave it to a couple hundred people, did they get an antibody response? Did they get a T cell response? Much less phase 3, which they really haven't gotten into. So they're saying maybe they don't need phase 3. It was hard to interpret that, or that they look so good now they're not going to complete it. I wouldn't want to rush to get that. I would think we really should be very cautious in accepting that at all.
Nancy asks, despite your discussion regarding testing, I must say that I'm still confused as to the efficacy and accuracy of the results. Do we believe tests or do we not?
Well, I think what we can say is we can, in general, believe them. But testing is complicated, and it's driven very much, what I've tried to say, by prevalence.
Yeah, so if you can unpack prevalence a little bit, I think for those of us who don't have MD.
Yeah, prevalence means of every 100 people in your community, how many have infection with COVID, silent or otherwise. And in general, in the country, it's thought to be about 8 or 9%. But some parts of the country, in Florida, it might be 10 or 15 or higher. If you have anything lower than 20, there are going to be a lot of false positives, even if it's a good test, the PCR test. There might be false positives. As the PCR test gets to 99% specificity, you do a little bit better than that. When you get to a high-risk population, so sick people in an emergency room, that's very high risk, high prevalence, very few false positives. So as a physician in the ER said, I just saw a patient. He had bad lungs, short of breath, sore throat, aches. This sounds like a duck. This is a COVID till proven otherwise. Even if that test came back negative, he would say, there are a lot of false negatives when I have a high prevalence. But false positives, no. If it came back false positive, this is really disease. So, and if you're just getting tested for all the school kids, low prevalence, nobody feels sick, there are going to be a lot of false positives. That won't hurt because there'll be very few false negatives. If you're a negative and you're lined up at your school and they said the test was negative, it's safe. You're probably really negative. If you're positive, false positives.
Gotcha. So I'll put this in context for myself. I had a little bit of a scratchy throat and a little bit of a headache that lingered. So Dana sent me off to get a rapid test, which still haven't gotten the results yet. But if it comes back and I'm positive, I feel fine. Good chance that I'm not sick, but should still follow the protocols. Sit back for 14 days, keep myself out of circulation.
That would be safe. And again, a priori, you're going to have close to 50% false positive,
Copy that. Okay.
even with those minor symptoms.
Paul asks, is there a connection between the recent increase in daily new cases and a lower death rate per case, and the fact that the population under 50 is almost double that of New York?
Yeah, I think that what we are seeing is younger people with lower mortality rates. And that is really good news. We don't know whether it's going to stay that way. And the worry is that the young people, if they're not careful, will transmit it to their parents, their elderly grandparents, and we may see actually a change in the demographics back towards an older population a little bit. So we would hope that the young people would really, even if they don't have many symptoms, go into quarantine, as you talked about, that they're positive. And if they get the symptoms, obviously, again, stay away from other people for at least 2 weeks.
All right, I'm going to do a selfish thing. I'm going to ask. I'm a baseball fan. Several baseball teams now have had outbreaks within the team, within the club, both players and staff. What do you make of that? Because there's been a lot of talk about, are they being irresponsible, or is this more of a reflection of they're just citizens walking in environments where they're not necessarily safe? In fact, we had the Washington Nationals refusing to go down to Miami to play because of not because of the team, the Marlins were infected, but actually because of just the danger of being in Miami and South Florida.
Well, again, the prevalence in the community is driving a lot of what you see. The second part is, what I would say that what teams should do is use the rapid test. And if it's negative, it's really negative because of the low prevalence most of the time. Your starting pitcher may have a false positive and you're stuck. But the players who are negative probably can play. And again, so you have those two things going on. You need testing, rapid testing, let the negative people play, so long as the community background infection rate is at a low level, preferably lower than 5%. So what's happening with those players? Are they not adhering to things? I'm not sure. Hopefully they're really being observant because they want to play. I'm sure of that. Everybody who's in sports wants to play the game.
Okay, Suzanne has a question. She says, as people are sheltering in place, like her folks, they never go out. Are they going to be more susceptible to other illnesses? Like, will the cold or flu hit them even harder? Do we need to help keep some contact with people to not totally destroy their immune systems?
No, you don't need a constant stimulation of infections to help your immune system. And I would say there are no higher or lower risk of flu just based on hunkering down at home. Again, they ought to get the flu vaccine. If they're at high risk for maybe underlying disease, they ought to take once a day during the peak period of flu. But no, they're not going to be at higher risk. And if they go into the community when they have to, let's say, go to the store or visit the pharmacist or doctor, wear their mask, they're probably going to cut down their rate of flu even. So by just the non-pharmacological approaches.
Okay, Paul is asking, and I don't know if we have this data, because the data's gotten so hidden or sent around in different spaces, do we have new deaths broken out into age, gender, race, and obesity?
And obesity?
Mm-hmm.
Well, so we know that obesity is one of the risk factors that CDC has there. And they've seen age groups, mortality. One of the things that, if you want to compare countries, the average patient in Italy was in the 60s. Our average patient is 48, until, let's say, very recently. So that may be one of the things that contributes to mortality. But we're seeing our younger patients with significant mortality, meaning 50s and 60s as well. So certainly the mortality that I saw earlier in the epidemic was that if you're over 80, you're 15% mortality. You're 70, 65 to 80, probably in the 5 to 10%, and lower as you go down. What interrupts that mortality, though, and actually can change things is how many of the risk factors do you have for mortality, like obesity, for example, an inflammatory disease. If you also have underlying heart disease and other risk factors as well, yeah, that will make a difference sometime. But in the categories of age, it seems to be a key driver.
All right, I'm going to take the privilege again. Let's pretend for a nanosecond, no one would ever actually want this, but let's pretend I'm president and I've invited you to the White House and I've said, tell me what to do, and then walk out and let's tell everybody together, this is the plan. Maybe there's like, if we think about new administrations, sometimes they have 100 days. What would be your 100-day plan for the country based on what we know right now, where we're at nationally?
Yeah, what I would do is have Tony Fauci and Robert Redfield go on the camera, review the data, and then tell people that, well, I think what we really need to do is have a 6 week lockdown, pretty much, maybe a little bit excuse for some areas with unusually low rates. We know it works. I'm talking about no bars, no nightclubs, no indoor restaurants, because for us to get out of that, I think we're going to have to do some serious lockdown. I would ask people, plead, them to support that and wear masks whenever they're in public. Try to stay more than 6 feet away if possible, but at least 6 feet away whenever we can. Those two things really work and can make a huge difference. Schools, it's really complicated. I think we know that if you close schools, uh, the infection rates will go down, the death rates will go down. If you keep them open, I think we have to have some threshold in the community where you say, okay, we have to then call that off. So we need leadership. Science alone will not cure a pandemic. We need leadership combined with science and public health to say, what are the facts? What are the assumptions underlying our current drive for the policy? And then ask the people to engage with us. Because if the people don't want to do it, we're in trouble. And I think we need leadership to bring that around. No matter what political party, we need combined political parties to get behind this.
Why don't we, and so maybe a final thought from you. Do you feel optimistic right now? Could you just characterize how you're feeling? It's early August. We've been talking with you since March. Do you mind sharing kind of what your perspective is just now?
Yeah, I think we dropped our guard and we had a sort of rebound of our wave that we had, and we know how to get out of it. Do we have the social will, the political will, and the leadership at CDC and NIH to get behind this and explain that? I think if we put those pieces together and with the promises of vaccines, I'm optimistic, but not for the next couple of months that we're going to do well. I think it's going to be a rough fall, and a rough fall for many reasons. One, continuing COVID, the new influenza annual epidemic. We're not immunizing our kids. We're going to see little breakouts of measles and mumps and whooping cough. We're having an unusually bad season of hurricanes, bad weather. We're going to see hurricanes, floods, and CDC has to deal with all that as well as the COVID. So they're going to be stressed beyond their imagination, I think. Now, if we look towards the winter, I think we'll have vaccines. We'll maybe have more drugs. I think we'll know if we're lucky enough to hunker down for a 6 week period somewhere in there and lower the rates. We have reason to look for a promising new sunlight, but not until we get into January, February, March.
So, absent a lockdown, the steps people can be taking are keeping that distance, sounds like starting to think about getting a flu shot if you haven't already. Tamiflu, there was a question in here about Tamiflu, or are there some other drugs that people can take?
There are other drugs that are out there that are equivalent, and they've been shown, one a day. And so you talk to your physician. If you're in a high risk group, even if you receive the vaccine, I would have that discussion. 90% protected. They're kind of not great drugs at all for the flu treatment, but preventive, amazing, 80, 90%.
Gotcha. Several folks are writing into the chat. I don't know if you can see it, just to express their gratitude, which we all share. Thank you so much for once again taking the time. I'm
Great pleasure.
just so incredibly grateful. I know we all are for the knowledge, because we're not getting access to it in other places, or we're having to go look for it all over the place. Another question Bill is asking, if you wouldn't mind, I'll put it on him. Would you mind
Sure.
coming back? We clearly are not out of this, and it seems like there's a little bit more ahead, or maybe
Yeah,
part.
no, if people are interested and it looks like it's helpful, I'd be glad to come back. We should talk about, what interval and so forth. Um, but I'd be delighted. I enjoy working with you guys, and I think you've done a terrific job trying to communicate what's going on.
Well, it would not only with your help. And so if you don't mind, we'll talk to you offline to figure out what makes sense for your schedule. But gang, it sounds like he's open to it. We know you are. Uh, we could all use a little bit more information and knowledge just now. And in the meantime, I guess let's leave it there, because we've gone on far too long and taken too much of your afternoon, but incredibly, incredibly grateful for your kindness and generosity. We'll all continue to do washing hands, keeping up the masks. Maybe a last selfish question, because we didn't get to this. We talked about this a couple sessions ago. Is it still okay to go out for a run, go for a walk?
Absolutely. Now remember, when you go for a walk, you want to go side by side. You don't want to go one person in front, one back, unless you're at least 12 to 15 feet behind or 20 feet. If you're running, again, go at an angle to somebody who's running in front of you. Don't go directly behind. You have to be at least 20 feet to 25 feet behind, because the droplets are from the person in front are coming back. So go at an angle, go in parallel, if you will. All of that's good. Remember, the distance increases if you're running faster or biking.
And masks while running necessary, or
No, I
you're
don't think
safe?
you need. If you're maintaining appropriate distance, you don't need masks.
Understood. And our friend Nancy is now teasing me and telling me how great the oysters are up in Cape Cod. Do you, must you? It's, it's just me. Nancy, if you want to send some to me, I'll send you my address. I wouldn't mind. All right, gang. Well, listen, let's leave it there. We will see Dr. Wenzel, sir. We will see you again soon. Hope you and your family remain safe and healthy. And to everybody else, let's just all hang in there, gang. It's going to be a little while, it looks like yet. I know it's hard to imagine, but it's going to be a while yet.
Thanks, Sean, very
All
much.
right. Thank you, sir. Be
Take
well.
care.